Hello, and welcome to the California Society of Anesthesiologists Vital Times, the podcast. I'm your host, Dr. Ludwig Lin. Today, I'll be speaking with two panelists, Dr. Wes Ely and also Dr. Zeest Khan, about long COVID, post COVID syndrome, and really the best ways to interact with patients who are presenting to us with these worries. Dr. Ely is a subspecialist in pulmonary and critical care medicine who conducts patient oriented health services research as a professor of medicine in uh, Vanderbilt University Medical Center in Nashville, Tennessee. He is a practicing intensivist and focuses on geriatric ICU care. Dr. Zeest Khan trained at Stanford University in the anesthesia residency, where I had the pleasure of being her advisor, and she then completed a cardiac anesthesiology fellowship as well at Stanford. Dr. Khan then had an enviable private practice career, first at Mills Peninsula Hospital in the Bay Area, then in the Central Valley of California. She had also gone into leadership roles and career coaching. However, at the beginning of the SARS-CoV-2 pandemic, she caught COVID and then developed LongCovid. Dr. Khan has now been on medical leave for the last 2 years. I wanted to use this space today to talk about the management strategies involved with LongCovid, but then really spend a lot of time discussing ways to really optimize our interactions as healthcare professionals with patients who are presenting to us with LongCovid. Before we start, number one, I would like to thank both panelists for taking the time to be here, and also to ask you if you have any disclosures to report. Dr. Ely?
And you're asking about potential conflicts?
Disclosures, yes.
Yes. Conflicts for me involve only that I'm academically supported by the National Institute of Health and by the Veterans Affairs Administration, but I do not receive any money whatsoever from big pharma or have any consultancies or stocks in any companies that make, for example, COVID vaccines, et cetera. So I don't have any financial conflicts with that regard.
Dr. Khan?
Thanks for having me, having both of us. Vig, no, I don't have anything to add.
Okay, great.
Disclose.
That's just something that we always should go over. Okay, so let's get started. The first thing I wanted to discuss is we all know and accept that long COVID is for real and it's here and it involves many different organ systems for our patients. What are some of the treatment and management strategies out there? Which ones are urban myths and which ones are actually effective? And we'll have Dr. Ely start with this.
Great. Thank you for this question. And let me first say, though, that there are some very prominent physicians in the United States and elsewhere who do not believe in long COVID. There are some people in California, since this is a California podcast, who are at very well-known institutions like University of California, San Francisco, who routinely discount long COVID research. And I just want to make sure that the people who are listening realize that this is out there, and I think it's misinformation. And we need to be more vocal about calling out misinformation, because patients who are suffering from this syndrome are not served by us discounting the ways that they're suffering, and they are the experts of their own illness. And we need to listen to them carefully and closely and accompany them, like Zeest will tell us about. They need accompaniment as they're going through this process to find their own recovery. And so I just want to make a point to say that at the outset. The other thing I'll say about specific treatments, is that we don't have any cure for long COVID. We think that long COVID is caused most likely by a prolonged antigenic stimulation from the virus itself or viral ghosts. That antigenic stimulation might be served by antivirals. It might be served by immunomodulators. We don't know, but we know that the virus initiated its effect on our bodies by attacking the endothelium at the ACE2 receptors and the linings of the lung. And we know those ACE2 receptors are in the brain. And so this ongoing inflammation affects, of course, if it's affecting the endothelium, affects clotting as well. So microclots and thrombophilia or love of blood clotting is part of it as well. And so right now, people are grappling with all kinds of different treatment approaches. Some are using anti-inflammatories, some are using blood thinners, some are using aspirin, some are using plasmapheresis. I have a friend who has long COVID in our support group who traveled to Europe, Eastern Europe, to get pheresis for 20 days running, funded herself. And my closing comment, and I'd love to hear from Zeest, is that I can't fault people who have long COVID for trying these things, even though they are not evidence-based and or proven therapies, because I am ignorant as a physician as to what might help another person to find their way toward recovery. And the first thing that I need to do as an informed evidence-based physician is say that the evidence is insufficient and immature. We are at the nascent stages in our understanding of long COVID and the therapies. So what I'm doing is I'm designing large-scale randomized controlled trials. I'll be submitting a grant to the NIH within the next month for a multi-center randomized controlled trial of immunomodulation. I'm also involved in some antiviral properties with antiviral studies with Paxlovid. And in the meantime, but while we're trying to get these answers, people are going to try things that don't necessarily have proven treatment. And some of them might work for some people and some of them might not. But what we need to not do is stigmatize people for trying to find a path to recovery.
I think that is the most important thing to remember. And I always have to remind myself, people aren't doing this, trying unproven therapies because they feel like it. I think it's a sign, a illustration of how desperate people are because they're in pain and they're fatigued and they can't move and they just really need to get better. That's the motivation behind it. Zeest, do you have anything you wanted to add to this?
Yeah, I think that Wes's comments were spot on. That there are some people who are giving some pushback on these symptoms because the constellation of symptoms that patients with long COVID present with does not have a visible or known through line yet. So, as a physician or perioperative physician, when you see a patient, you're going to have that patient's going to have a potentially very long list of diagnoses, a potentially long list of adverse reactions or allergies to medications, and a long list of medications. It is frustrating to hear, Wes's comments, which are true, that we patients are the experts of our own illness. It is very, very burdensome to be a patient and the director of your treatment. So this is a lot of trial and error, and that is a slow-going process. So to list some medications that patients often try, will also I'll also comment on the symptoms that patients have. Many patients with long COVID have disabling fatigue. I've gone over some of these in my CSA, in the article that I wrote for the CSA of what to look for and what to expect with a patient with long COVID who presents to the operating room, because you're going to see patients. So disabling fatigue, patients may use stimulants for that, and those could be medications that are used for ADHD or narcolepsy. Patients have dysautonomia or orthostatic tachycardia syndrome, POTS. You're going to see patients on beta blockers. You're going to see patients on midodrine to help low blood pressure. You're going to see patients on low-dose naltrexone, which personally has been the most effective treatment. And I know anesthesiologists are heading research on low-dose naltrexone as a treatment for acute and chronic pain. At higher doses, ones that are produced by manufacturing companies, naltrexone is used for substance abuse deferment. I don't know what the right word is, but at low doses, it is helpful with glial inflammation. And so low dose naltrexone has really helped my cognition. I, like many patients with long COVID, have a full and expensive medicine cabinet in my home that includes many supplements. Some are anti-inflammatories, some are uh, sleep aids. So you're going to see patients with a long list of medications. In addition, the adverse events are notable because patients with long COVID we found are very sensitive to medications. So the therapeutic window for medications is quite low for us, or narrow. So you may see patients with a long list of adverse reactions. It may be dose dependent. They may not be, anaphylactic allergies, but think about that. But when you're looking through a patient's chart.
Great. Thank you for that list. That I think that's useful for all of us. I'm curious about the naltrexone aspect, because obviously a lot of anesthesiologists are used to considering opiates as a part of their balance technique for general anesthesia, for example. And do you feel like the extra sensitivity of long COVID patients will interact with that? But also, the long COVID patients who are on naltrexone, might they not react to opiates in the usual fashion?
Wes might have more to say about this. In my experience, these doses are very low. I think manufactured pill for naltrexone for substance abuse is something like 50 milligrams. I started off at 0.1 milligrams of naltrexone. I've had a couple of surgical procedures, and I have not had an issue with pain control. If anything, I've been still very sensitive to narcotics.
Good to know. Wes, do you have any thoughts about this?
I agree exactly with Zeest's point that in clinical practice, we routinely use 50 milligrams a day of naltrexone, and the doses that I see long COVID patients using are way smaller than that. And I haven't worried about health effects in a negative fashion. And my mental approach to this is, hey, try it if it helps you. I don't think it's going to hurt you. And for some people, they really do find that it helps to clear their cognition. I don't have data behind that. I don't have any kind of level 1, level 2 randomized controlled trials there, but people are grasping for therapies that I think if they can grab them, those that won't hurt them, but might help them. I'd rather that than try something that might actually cause them harm.
Right. That's a really good strategy. You were mentioning, Wes, that you know we should be thinking about ways to advance the medicine in this area by having data-driven decision making, and that there isn't any right now. So everybody is just sort of taking their best guess. But I definitely am curious about what your best guesses are in terms of the management strategies, the the medications that are potentially useful for patients with long COVID. Do you have any that are sort of, on your list?
Sure. Well, let's start with what we learned at the beginning about acute COVID. Acute COVID, when Zeest and I were in the COVID ICUs and when she got COVID, whatever, back then, we realized early on that we could give people either anti-inflammatories or antivirals. The first two things were remdesivir and corticosteroids. And so that is kind of a theme of what might be the approach to long COVID, which is hit the virus, hit the downstream inflammatory problem of the virus. And that's the way that we're going to approach this from a clinical trialist perspective. Now, if you ask what are the established treatments of acute COVID, The best immunomodulator that we've ever found yet thus far is baricitinib, a JAK1/2 inhibitor. I would disclose that I did the original trial of baricitinib. I do not have any financial conflicts of interest with baricitinib. I didn't take a single penny from the maker of that, which is Eli Lilly. I don't have any stocks in Eli Lilly. I'm not a consultant for Eli Lilly, et cetera. But I did design the clinical trial. It did save lives, and it's now FDA approved. The only other fully FDA approved drug for COVID is remdesivir. So there's only two. Paxlovid is an emergency use authorization, EUA. And I think that those are the best places to start. Antivirals and immunomodulators, those are going to be, patients with long COVID are going to be asked to enroll in such trials. And whether they work or not, I have no idea. I mean, it may be that we come back in a year, Ludwig, and you and I and Zeest are here saying, well, it was worth a shot, but it didn't work. I think that as we're designing these trials, we have to have safety in mind first. So we have to have great safety monitoring. For example, are people getting reactivation of viral illnesses like EBV, CMV, HSV when they're taking these drugs? Is the antiviral itself causing them drug-drug interactions that are hurting them if they're already on medications for other comorbid illnesses? And all this stuff just needs to be monitored very carefully, and it will be. But that's why I want to encourage people listening here to not go doing these two medications on their own. I don't feel bad at all about people trying naltrexone or working with a cardiologist with POTS, taking a beta blocker or taking midodrine under the care of a physician. But I do think that it's potentially very dangerous for people to be self-medicating those sorts of drugs that can cause heart block or that can cause hypotension and people to pass out, perhaps while they're driving a car. And for antithrombotic agents, we don't want people bleeding if they fall down, because they were trying low molecular weight heparin or something, because all those things have been done through self-medication. And I hope that people can try things that won't be, that would be more in the safe zone.
Such a good point. My favorite saying is there's no free lunch. It kind of applies to life, but it definitely applies to uh, um, medical practice and medicine. Everything has a side effect, right? So, and for example, critical care itself is littered with various well-meaning strategies that turned out to either have done nothing or be harmful. So I appreciate you really making that point to all of us once again. What about the reactivation of things like EBV and CMV that you were talking about? What are your thoughts about that? Because I think some people are just doing that empirically now for long COVID patients.
If you think about what we think is the proposed mechanism of long COVID, you've got when somebody gets infected with a virus, like Zeest, when you were infected, we know that direct tissue damage occurred, that cytokines were released, and that there was then a systemic cellular and antibody response to that viral injury. Well, when that occurs, that immune reaction can cause latent EBV, HSV reactivation. And that sort of reactivation might be what then causes that. That's one of the 4 or 5 things we think that might cause, ongoing immunomodulation in the body. Where Zeest mentioned that astrocytes, can be helped. Glial cells, the glial cell inflammation can be helped with something like naltrexone. That's what we think is actually happening. Is that in people's brains, the glial cells, the support structures for neurons, are activated, primed, and stay primed for many, many months. And that then creates an abnormal environment for neurons. So if the neurons aren't supported, they die and they go through neuronal apoptosis. So that viral reactivation can be part of that. We don't know yet, but that's what's been seen in animal models to date.
My
Okay.
poor little neurons.
I'm worried about your neurons, Zeest.
I am too. If I could, Ludwig, pipe in with what Wes was talking about safely
Please do.
using these meds, it's really important that physicians believe their patients and have an easy way to learn about options they can offer their patients. people with long COVID are taking drastic measures to find medications that they hear work from other people who are not physicians. And the reason they're doing this, going to Canada or Mexico for their meds, hiring physicians or healthcare providers, paying cash to get prescriptions, is because their local physicians don't believe that they're sick, or or they can't find a physician who has any quote unquote expertise in this or feels comfortable trying to prescribe medicines for these patients. It is really scary, the stories I'm hearing of patients doing anything they can to find meds from places that are not their pharmacy.
Yeah,
Mm.
it's
That's
it's
worrisome.
heartbreaking. It's heartbreaking, really. So, Zeest, I think you wanted to have people think about this, and what would your suggestion be to really be ready to 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 know that that's what's happening out there? Is that right?
Yeah, so I've been, my full time job is to recover. So I've had a lot of time to think about my field and how the field that I dedicated my life to doesn't have the answers for me when I am in my time of need.
Yeah.
There is only so much that physicians can do, and we know that physicians and other healthcare workers are very, very taxed right now. But my husband is in not in medicine. We lived in Silicon Valley for many years, so he's in that realm, and we were exposed to that workflow culture of trying and failing and modifying and innovating. The medical field we are in values safety. It is true, and that is very, very important. But when COVID hit, we had to modify our workflows very rapidly. We were listening for the latest treatment strategies. You and Wes would know this best working in the units. We're hearing this is helping right now, so we're going to try to postpone intubation for as long as we can. Remdesivir is available. We're going to try that for a certain subset of patients. And we shared information at a mass level. With long COVID, we need to do something similar, but without, luckily, the trauma that occurred, to our psyches during COVID, when people continue, their lives continue to be damaged. But I guess what I'm trying to say is, how do you teach physicians about something new like this that is very pressing very quickly? And I'm concerned that our medical field does not have the practice or the culture of modifying our workflows like this and approaching a disease that is new and being able to say comfortably, you know what, I don't know a lot about this, and admitting that to a patient.
I don't think we, as a profession, are trained to be able to do that. We don't admit that we don't know everything. It takes so much to be able to say something like that. So thank you for making that point. Wes and I did part one of this podcast where we talked a lot about the impact on different organs of by long COVID, and that's available on the Society of Critical Care Medicine's podcast series. But we talked about this. We talked about how it's really important to just acknowledge that we don't know everything, be very upfront with that, and have that be sort of like um, the welcome to draw each patient into this conversation. And as you were
I'd love to
talking,
comment on that a
oh,
little bit,
yeah,
actually.
please do. Please do.
Yeah, I love what you said, Zeest, and thank you for bringing that out. It's a beautiful point, and we too often don't admit when we don't know something, and or when we're outright wrong. I had a patient that started crying with me in the ICU when she had her COVID and her lungs were failing, and she's through tears. She said, Doctor Wes, do you want me to tell you why I didn't get the virus, or didn't get the vaccine? And I said, that's your story to tell, but if you want to tell me, I'm here to listen. And she said, first, tell my family that I was wrong. Tell my family that I was wrong about the vaccine and that I want them to get vaccinated. So here was a woman dying of COVID, admitting she was wrong, and physicians like me are too unwilling to admit when we're wrong. And she was my teacher that day. And then I knelt down by her side and I looked her in the eyes and held her hand and just said, I just want you to know that I don't have all the answers for your illness, but I'm not going to leave you. And I'll be present with you and go through this with you, and you will not be left alone. And she went on to tell me that the reason she didn't get the vaccine was because, and I quote, and I have permission to use this story, although I will not use her name. She said, the man on the TV said they were trying to depopulate society of people like me. And my heart just sank because I thought, this woman is a victim. She's once again, a victim of misinformation. And sometimes it comes from doctors. Sometimes it comes from Congress people in politics, or anybody in a leadership position. And so she was misled. She then wanted to admit that she had been misled and was wrong and have her family get the vaccine. And they did, by the way. The family listened to her and got the vaccine. But it brings me to this point that I wanted to share with you. And it comes from, it's a paragraph out of Every Deep Drawn Breath. And this is a book that I wrote about patients and what I learned from them. And in this place, I just reflect on something that my patients taught me. And I'll just read this paragraph. I had read Ignatius of Loyola's Spiritual Exercises, written in the 1500s, in which he teaches about our frequent failure as humans to attain fullness in relationships. And I began to understand the impact of my failings on my patients. I'd cared for them and wanted to do my best for them as their doctor, but I was treating them as inanimate objects in what philosopher Martin Buber describes as an I-it relationship. I'd collected data and analyzed and classified them, seeing my patients as a set of organs to fix, a list of problems to solve. And I think that, by the way, this happened a lot in early COVID, Zeest, when you were talking about how we were approaching our patients. I had read and recommended Samuel Shem's novel, The House of God, about an overworked intern learning the ropes in a hospital. Shem's narrator, while hilariously entertaining, depersonalized patients, using disparaging terms such as Gomer, get out of my emergency room. I saw now that I, too, had shown callous disregard for some of my patients. And my closing comment would just be that, when I was a medical student, my mother gave me a leather-bound copy of Osler's Aequanimitas, the Latin word for equanimity. And I'm not reading anymore, I'm just talking. I think that I had taken Osler's advice of keeping an even keel in medicine and not showing my vulnerability. I had taken that advice, which was well intended, and I'd overused it until that asset became a liability for me and my patients. And during COVID, I became a liability for my patients, but when I wasn't willing enough to dive in to their suffering. And the way I want to live going forward, and I think what I learned through COVID is that I want to live out what I consider the definition of mercy, which is my willingness to dive into the chaos of another person's life and provide lifting and healing. And as an ICU doctor for many years, I did the first part of that definition, but not the second part. I was willing to dive into the chaos, but I wasn't always seeking, Wes, how are you providing lifting and healing? And in COVID, many times I didn't provide the lifting and healing when they were behind the glass and the family wasn't allowed and I wasn't in the room with them and so on and so forth. And I think I operated out of fear. And going forward, I want to operate out of love and mercy instead of fear.
That's beautiful. Thank you. I think that's a call to arms for all of us, really, to change the way we process, the way we take care of patients and people. Maybe seeing patients as people first. I'm kind of speechless right now, but Zeest, do you have anything to
Yeah, I
add?
think that's really heartwarming, Wes, and thank you for sharing your book and your thoughts. I think it can be really simple for physicians. Where this podcast is going out to anesthesiologists. We have hubris in our field. Um, it's just built in to it. Some of it is a defense mechanism because we see such brutal things and have to make such brutal choices that we want to believe that we're right. And it does help us most of the time. Uh, every once in a while, it might be nice, however, to approach a patient who might have a very long list of allergies and a long list of diagnoses and a long list of meds. And I'm sort of winking as I say this because it's a shorthand for a difficult patient, to say what works for you, what doesn't work for you, and to actually listen to that. What is this diagnosis that's listed? I don't know. I don't have a lot of experience with this. And let the patient explain it to you. After talking to plenty of people who are not physicians, but patients, that's very refreshing to hear. And the words, I'm sorry you're going through that. I can't guarantee that you're not going to have side effects from the procedure today, but I'm going to keep what you told me in mind. And I'm going to try to avoid the things that didn't work for you. And I'll try to do the things that did work for you. That is an invitation to collaborate in a field that is usually has a really strong power dynamic and a really strong hierarchy. And so I would suggest to give it a try. Try to collaborate with your patients, especially as you see more and more patients with complex disease that may be the sequelae of a viral infection.
Thank you. That is really good for all of us to hear, I think. That was one of the questions I really wanted to ask both of you. And I'll just ask now, even though I feel like Zeest covered a lot of it. What are some of the pitfalls of a well-intended but maybe short-tempered or scared healthcare worker faces when approaching a patient with long COVID, and what are the some of the essential points that they should consider when they're interacting with a patient presenting with long COVID?
Well, I'll speak as a physician who talks to these patients, talks to long COVID patients regularly, and gets approached about what should I do next, what treatment should I get next. And one of my pitfalls that I try not to fall into is to poo-poo an idea that they might have just because I have not seen a randomized controlled trial of it. And I try, and Zeest, I'd love to get your feedback on this if this seems at all reasonable, because I know, it's not a one shoe fits all, and maybe it worked for some and not others. But I try to tell them right up front, we don't have great medical science on this, but each person with long COVID requires a completely individualized approach. And I do not think that carte blanche recommendations for long COVID patients are going to work, because the types of disability and injury that people manifest are so different. Somebody might have more GI disturbances. Another person has way more POT symptoms. Another person has almost primarily cognitive symptoms. And this sort of spectrum of illness makes me as a physician have to step back, realize that listen and silent have the same letters. And so I need to stay quiet and keep my mouth shut and listen to them describe what is going on in their life. And as Z said a minute ago, ask the question, what matters to you and what has been working for you, and how are you suffering the most? And I will work with you to try and find the best individualized approach that might work in your life. And we'll do it by trial and error. and I won't abandon you. I'll stay with you.
Wes, I think you're bringing a lot of healing to your patients that way. If you're approaching them like that, I think it's great. I am looking forward to the time where there is a one shoe that fits all of us. I'm really angry that there isn't a medication that's treating my underlying pathology. Right now, I think what we're speaking to is that the treatment for long COVID is symptom management. It's symptom management. We don't have a marker of disease severity. We don't have a marker that tells us that the treatment is working for the long run. This is symptom management. And if we're talking about a disease that is affecting, something as diverse as post-viral inflammation, it's going to attack no parts of the body are immune, no organ systems are. So, yes, what is most important to you? What is bothering you at this time the most? My personal treatment strategy has literally been what is my biggest problem right now, and how do I take care of that organ system right now? And then I'm going to go to the next one and the next one. It isn't that the first organ system is cured, it's just that the symptoms are better. And I have a way of managing it a little bit. This condition really, really stinks. I have a lot of patience and a lot of perspective because I did cardiac anesthesia and I did trauma, and I know that I am not sitting in a bed in an ICU with a sternotomy wound, and that I'm not on dialysis, and that I don't have heart failure right now, but I can barely leave my house, and I am a cardiac anesthesiologist from Stanford, and people's lives have been devastated by this. So the least that physicians can do is approach their patients with a little bit of an open mind, which I hope would also allow physicians themselves to have a little bit of what Wes said, mercy on themselves, and ask themselves, what do I need to get through this? Because there's a lot of suffering among healthcare workers right now too. So I said a lot there, but that was what was on my
That's a
mind.
wonderful answer. I love everything you just taught me. And I'm listening to you. I'm your student right now. And thank you for sharing that hard won wisdom with us today, Zeest. I truly am blessed to hear what you're teaching me. And the way I'm going to use that is that I'm going to stay resolute in designing good science as a physician scientist, and also just continue to realize how small I am in the understanding of this problem, and be open-minded to learning from people like you who are trying new things that might give us, and sometimes we learn an awful lot from anecdote. And we need to realize that these anecdotes of people like you who are a scientist and you're going through it, you might spark the next right trial that might come up with, one of the major treatments for long COVID as we go forward. And so I'm listening and learning, and thank you.
I'll tell one funny story to follow that up about having a scientific mind while also dealing with this. I don't have it as often, but I was very pre-syncable earlier on for a long time. And I remember being in the bathroom of my bedroom's bathroom, which is pretty big, and I suddenly fell to the ground because I could not stand up anymore. I knew I would pass out and I had to get horizontal. And my face was on the bathroom rug. And my husband was a little shell-shocked, but sitting with me and asking what he could do. And I was quiet for a long time. And he said, "What's going on?" And I said, "This is fascinating." Because I mean, it's just, if I hadn't been going through it, I can believe why some people are hesitant to believe that something like this, that these symptoms are real. because it's almost too difficult to believe.
That's so crazy. Wow. The fact that you had the wherewithal in the midst of a near syncable episode to be amazed that your body was manifesting itself this way in long COVID, that's a crazy good story.
Yeah.
Yeah, it is crazy.
And
But I
sad at the
also
same
think
time.
that's why it's so powerful to hear from you, Zeest, because you are filtering all of these experiences through your mind, which has gone through extensive advanced medical training. So it is savage and powerful. I wanted to ask you a couple more questions about this, actually, Zeest. You said that you've gone through a couple of procedures yourself. Can you share with our listeners what surprised you about the way sedation and anesthesia affected you?
Yeah, it was horrific. I had fantastic anesthesiologists at a wonderful California institution with very, generous and supportive staff around me taking care of me. But intraoperatively, I was very tachycardic. Post-operatively, I had some delayed emergence. I was very sensitive to stimulation. I was very sort of confused. I would call it post-op delirium, but I sort of knew what was going on, but I didn't understand what I was present. I guess present of mind, but couldn't understand what was happening. I kind of compare it to like machines. I thought I was having my body was malfunctioning, is what it felt like. And the recovery process was very long. This generalized malaise and fatigue that I have not seen a patient recover that way. Um, I had a very bad headache, kind of like the worst headache of my life. Now that we have a little bit of a sense of endothelial damage, I've gotten a neuro evaluation to make sure nothing's really um, worrisome in my brain vessels. Um, the bottom line is, uh, these patients, I was very sensitive to anesthetics. Um, and even under, careful watch, it was difficult. So much so that the subsequent surgery I had, I deferred anesthesia and I had it done under local when a lot of people would have had at least some sedation. So I would recommend, if possible, even though space is really, really tight, to have either sunglasses or a towel over the patient's eyes. If your facility has headphones, provide that. Sort of sensory deprivation and approach it like a traumatic brain injury patient. Um, I don't have, lab data to suggest that, but that's when my cognitive impairment kicks in. It reminds me of what a concussion must feel like.
Yeah, that's what it sounds like. And I think Wes had said, we have very little data, and maybe this is something we should inspire somebody out there to study. Like, I'm thinking, what was your BIS score? Does it matter, or could it show that uh, you were responding differently? So lots of questions. Uh, I feel like there's just so much more to talk about. Having said that, I am cognizant that we are drawing to the end of this podcast. So I wanted to ask both of you if there were additional thoughts or memories or any points that you really want to make sure that you say to our audience before we wrap up.
Go ahead, Zeest, please.
I would say to physicians who are practicing, please take care of yourselves. Please allow yourself to admit that you're tired, that you need food, that you need a nature break, that you need a hug. um, take care of yourself. You only have one body. We really, really demand a lot of our bodies in this field, in anesthesia and ICU, maybe more than some of the others. And when it works, it's great, but it you're in my family's religious tradition, which I'm not religious at all, but I often think of this as there's a passage from the Quran that says your body has rights over you. And I think we forget that and we abuse our bodies a little bit in medicine, and we need to take care of ourselves. So advocate for yourself.
Wow, I like that. Yeah, we should honor our physical beings. You're right. We don't do that. Wes?
I'll close, since we have an audience of medical professionals as well, by commenting twice. One is, I think too often in medicine we think of our vocation as one of benevolence, like trying to do good. But I think that we have to hold medicine up to a higher standard, one of beneficence, actually doing good. And in the case of long COVID, when you don't have an answer yet, we have to ask ourselves, how do we actually do good? Well, we actually do good by allowing ourselves to have a full relationship with our patient, listening to the whole person of who they are. And that means looking at a person and saying, this is not just a physical body, this is a mind, a body, and a spirit. And if I can pay attention to all of who you are, Miss Smith, Mr. Jones, then I need to ask you, what matters the most to you? How do you get by in the stressful times? How are you coping with this suffering you've got when I don't have an answer to give you yet? And the second and last part would be, don't give up hope that science is coming and the body is going to be able to recover down the line. We think the brain, for example, has incredible capacity for neuroplasticity. And we don't believe that people time out. There are people we've treated with post-intensive care syndrome, PICS, that years after the ICU, they've used cognitive rehabilitation and gotten themselves back again. So I think that you have to maintain that hope. We as healthcare professionals have to shoot for beneficence, and that comes through loving our patients and having mercy to dive into their chaos and provide lifting and healing.
Thank you. And I also wanted to add that Wes and the Vanderbilt group have always had this amazing webpage. We were talking about it the other day, about delirium, and that has a webpage of icudelirium.org. And you've just added a whole section on long COVID, right, Wes?
Absolutely, we did. And so if you just go to icudelirium.org, under the patient and family page, there's a long COVID page, which has lots of resources, lots of symptom complex advice and thoughts, and also risk factors to address, etc. There's also a paper, for example, I wrote a piece in Stat News last week on the haunting brain science of long COVID that has over 20 references in that one piece. So we found that people already this week have really thought it helpful. So I hope that it serves others, and we're open to suggestions for how to improve the website. But that's why it's there. It's there as a public service. There's nothing to sell you. It's just there as a public service.
Definitely go check it out, everybody. I think, this is a great way to get some uh, honest to goodness medical information. And there are resources, there are ways to get more information, people to contact. So definitely check that out. I also wanted to add that Wes did mention during this podcast that he wrote this book. So he's the author of a book named Every Deep Drawn Breath, and 100% of the net proceeds are actually going to go toward helping COVID survivors and family members rebuild their lives. So that is for sure a worthy cause. And like I said, we could talk so much more about all of this, but I will wrap it up at this point. And I wanted to really thank both Wes and Zeest for taking the time to be here. I think that this was an intensely emotionally powerful conversation. It was very much authentic. I think it was raw. Hopefully, all of us learned from it, and we need to. And I think we're going to come out the better in terms of the way we treat patients with long COVID. But maybe we can also, as Zeus mentioned, be kinder to ourselves. This is going to conclude another edition of the California Society of Anesthesiologists Vital Times, the podcast. Thank you all for joining us. And remember to rate, review, and subscribe this podcast series. I'm Dr. Ludwig Lin.